Hello, everyone. I'm Margaret Yacobozi. I am a breast imager at Wake Forest, and I'd like to thank everybody for spending a bit of their evening with us. What we're going to do today as part of the SBI Summer Series is go ahead and talk about breast procedures. So before I do too much more, I would like our panelists to go ahead and introduce themselves. Stephanie, we can start with you.
I can start first. My name is Stephanie Chun. I am a breast radiologist at Cooper University Healthcare System, which is centered in Camden, New Jersey, and have been in practice as a breast radiologist for 3 years.
Hi, everyone. I'm Stephanie Chan. I'm an assistant clinical professor at UCLA. I am entering my 3rd year as faculty, and I also did my fellowship here as well, too. Very excited to be part of this talk today.
Gretchen?
Hi, I'm Gretchen Stibig. I'm a breast imaging radiologist. I've been at Long Beach Memorial for many years in private practice in California.
I'm Colleen Sheth. I'm the medical director of breast imaging at the USC Norris Cancer Hospital in Los Angeles. I've been here for 20 years, and I'm excited to be here.
All right, great. So what I would like to do is just go ahead and start from the beginning. What is a breast biopsy and who needs one?
Anybody want to take that?
I guess I could give a general kind of summary. So a breast biopsy is going to be a minimally invasive procedure that we do for suspicious lesions in the breast. These are lesions that we see on imaging of some kind, whether it's by mammogram, by ultrasound, by MRI, and it triggers our suspicion that it could be a breast cancer. So anytime we have basically a suspicion of greater than 2%, we like to do these biopsies, and they're always image guided, generally done by the imaging modality that we see at best. And we use imaging so that we can be very accurate in getting the right sample of that area, and we can avoid any important structures like blood vessels or the lungs or muscle, for instance. And the whole point, of course, is to get a small sample of that area that we send to the pathologist, and they will help us determine whether it's going to be a benign finding, which is what we're all praying for, obviously, a malignant finding, which means it's cancer, or something kind of in between called a high-risk lesion.
All right. And you touched on it a little bit, but can someone go through the different types of breast biopsies?
Sure, I can take that one. So we use a variety of imaging modalities in breast imaging: mammogram, ultrasound, and breast MRI. As Tiffany mentioned, we tend to do the biopsy with the imaging modality we see best. Often, ultrasound is the easiest for both the patient and the radiologist. So when we can do things by ultrasound, we like to. But as she also mentioned, we tend to do it in the imaging modality with which we see it best. And we have the capability to do an MR-directed biopsy, mammogram-directed biopsy, also called the stereotactic biopsy, or ultrasound-guided biopsies.
And what's the difference between an excisional biopsy and what we do as radiologists, the imaging guided biopsies?
I'll take this. Or go ahead, Greg. Go.
No, that's okay. Go ahead.
An excisional biopsy is a surgical biopsy, and it's usually done in conjunction with the radiologist, where the radiologist will guide the surgeon to the area of interest, either with imaging. So as we mentioned, mammography, ultrasound, and MRI as potential imaging modalities. Either a wire or a wireless device will be placed in the breast in the lesion of interest, close proximity, so that the surgeon can do a more targeted dissection to take out the area of interest. These are usually done when a core biopsy is either not easily feasible, or a biopsy was done but with inconclusive or indeterminate results that would warrant a more amount of tissue to be sampled. The other hand, the more traditional way of biopsying the breast is by a core biopsy or a minimally invasive biopsy. These are interchangeable terms. This is where the radiologist, as Dr. Chan was pointing to, uses a small needle to sample a little bit of tissue from the breast using the modality that we see it the best, usually ultrasound, but also mammography or MRI when needed. And those are done in the radiology suite with imaging guidance, and a clip or a marker is placed afterwards to mark the area until the pathology comes back.
So you mentioned about the clip, and a lot of patients, they have questions about the clip. Can you explain a little bit more what is the clip and why do we put it there?
Yes. So a clip is essentially a marker. It's a placeholder to until we get the pathology back, because most of the time we don't know what the pathology is, if it's cancer or benign or a high-risk lesion that's in between, until the pathology comes back, maybe up to 5 days to a week later. So the marker is a inert device. Generally, it's very safe. It's pretty small. It's generally either made out of a tiny piece of metal or sometimes another biologically safe material that will basically be seen on imaging, hopefully an ultrasound and mammogram and MRI, so that it could be localized at any one of those modalities. But it's placed through the needle, through the tract, into the area that was biopsied. It's not painful. You don't need to make a separate incision of any sort to mark the area. It's just dropped into the cavity where the biopsy is done. Different manufacturers make different types of clips. They come in different shapes, maybe even different sizes, different materials, but they're generally very safe and well tolerated. Women can walk around with these clips and no one knows that it's there. Again, the most common question I get is, will it go off in a metal detector, or will it beep in an airport? And the answer is no. They can sometimes migrate a little bit depending along the track if there's been a little hematoma or during the placement, but generally it's fairly accurate. And if the lesion comes back benign, they stay there. It's not removed, and it's very safe. This does two purposes. One is it identifies the area that was biopsied, and it correlates that with the patient's pathology history. And if there's a new lesion in the future in the same area, it helps differentiate which lesion was biopsied, and so they don't have to go through another biopsy. And if it's obviously if it's cancer or suspicious or atypical, and it needs to come out, then the surgeons or the radiologists can use it to localize or target it at the time of the excisional biopsy.
All right, great, thanks. So when we do these procedures, what is something that you would like the patients to know beforehand? What's something that they should know, or what are they always asking before a procedure?
I think in our case, well, I think you always have to get informed consent and explain what the potential risks are, which are quite minimal. It's just getting a big hematoma. We have no major blood vessels, so it's not like any significant bleeding can happen other than an enormous hematoma. And the other one is infection, and extremely unlikely with people who have a lot of experience. I guess I've known of people who've gone into the lung, but I guess that's really unlikely. So we don't really mention that. We only mention bleeding and infection because we've never had that problem. I think in general, people want to know how soon they can go back to work. So we want to tell them, do you have a physical job, or do you have a desk job? And depending on that, if there's an aerobic instructor, she might have to take a couple of days off. And if you're a lawyer, maybe you go back to work. Mm-hmm. So it kind of depends a little bit on that. I think people also want to know how much it's going to hurt the next day, and what they can do to make that less bad. So we in general tell them that they can preemptively take Tylenol if they wish, and that in general, an ice pack tends to be the best thing to lower the amount of pain. Mm-hmm. So those are the main things that I think people want to know.
All right. Anybody else have anything that they have patients asking them before procedures?
I usually like to tell the patient that while significant bleeding in terms of life-threatening bleeding is not really a risk, that the hematoma can be, just a little bit of bruising on the breast, nothing at all, or a pretty significant purplish discoloration of the breast. And while that is unusual, it can be within the realm of normal and not to be too alarmed. And, they can always call us if they have an issue. And then also I found from women that they've mentioned to me after their procedures that when they wear a sports bra or something with compression, a shirt with compression and support, they tend to feel a little more pain relief and comfortable after the biopsy. So I like to mention that as well.
I was going to ask the panelists, but we've started putting ACE bandages on almost everybody who we do a large core, just because it just makes the bruise be smaller and go away quicker. So we figured, why not do it if they don't oppose it? Is anybody doing that or not really?
We routinely do a bias wrap around the breast, like a tight sports bra. It's equivalent, I guess, does the same thing. And that's worked very well. We haven't, it feels very tight, and at first the patients say, I can't breathe. But they can breathe. It's just it's secure, and actually we find many like it because they feel a little bit more protected. They can wear it underneath their clothes, and it works really well. We've been doing that since I've been here because Dr. Silverstein, one of the breast surgeons, kind of wanted it for his patients, and we liked it so much we've done it for everybody. And we get very, very infrequently do we get any bleeding or bruising.
Very nice.
So even with 14 gauge, you do that?
We do it. We use 12 and 14 gauge needles 9, 12, and if it's a 16 gauge needle for the axilla or something, we won't do that. And we don't do it for aspirations. But in all the vacuum assisted core biopsies, we do it.
Yeah. Okay.
And that brings me to aftercare. What do you all recommend for after a breast biopsy? We talked about ice packs and kind of a sports bra, but is there anything else, any restrictions you want on the patient and for the patient to have?
I think for like water restrictions, in the sense that we always say to shower 24 hours after. So if someone comes in for an 8 a.m. biopsy, we usually say, hey, by tomorrow around this time, you can take a shower. You don't have to do anything crazy with the area that was biopsied, just kind of, dab it dry. And most importantly, try not to soak the area for the next few days. So soaking can range from taking a bath to, since we're in LA, going to the ocean, hot tub, anything like that. Obviously, we tell them that the risk of infection is fairly low, but it technically could happen because we are breaking the skin barrier. Last thing I want is for some water to get in and cause an infection. So that I think is kind of important because a lot of patients get very anxious in the biopsy. They're getting sweaty and they're like, when's the next time I can take a shower? I'm so nervous. And we're like, take it easy. Tomorrow probably is the best time. With lifting, I think we talked a little bit about that. I put it in terms of even carrying groceries or carrying children, because even if you're not actively working out, lifting dumbbells, really lifting, a few pounds can be rough. And we want the skin we want it to heal nicely next to each other, not to get sheared or to go out like this. So I always say that they have a free pass, at least for the next day, with carrying items and that sort of thing. They can always get some help for that.
Yeah.
All right.
Yeah, I usually suggest nothing heavier than something like a gallon of milk in that arm, or also I think you mentioned yoga instructor type of job, but vigorous overhead motions with the arm, just to not cause that skin to open again and have the hematoma express on the patient's clothes.
Okay. One of the things I wanted to touch on is what we do after a biopsy as radiologists when the pathology results come back. So we look at the radiology, the pathology, and see if it correlates.
Mm-hmm.
Can anyone talk a bit more about that? What does it mean if it does or doesn't, and how do we decide in general?
Well, I think, we all look at our pathology and determine if it makes sense with our imaging findings, something that's called radiologic pathologic concordance. And so it's a very important part, I think, of the biopsy of our job to make sure that the area that we are sampling is, one, the question area initially, and also, if it's representative of if the samples we've taken are representative of that finding. So it's very important to determine whether or not the pathology results are expected based on the appearance of the radiologic finding. And so the biopsying radiologist will review the pathology, review the original imaging to ensure that, yes, what the pathologist is seeing under the microscope makes sense with what we're seeing on the imaging. If it does not match up, if there's a very suspicious lesion, the pathology result is returning as something benign or benign breast tissue that doesn't match, then that would warrant initial or additional intervention and additional steps, which may include a repeat biopsy or a consult with a surgeon for excision.
All right. Anybody have anything else to add? Do people generally do these by themselves? Do you meet as a section, or how does that work? We generally do them ourselves and with our residents and fellows.
Yeah, that's what we usually do as well too. One thing that I was always taught about RAD-PATH correlation is that it's very important because we're the only ones, the ones who did the biopsy, are the only ones that know what happened during the procedure, right? We are obviously taking intra-procedural imaging, pre and post, pictures with our biopsy needle, going through the mass and that sort of thing. But at the end of the day, static images only tell part of the story. So the radiologist, whether it's the attending, the trainee, or both, we're really the ones who know what happened during a biopsy. So of course, we're the ones who, do the RAD-PATH correlation as well. Sometimes, this is probably the most important part of our job. So we do consult one another whenever we're not too sure, because our recommendations are very important. We're telling people, hey, don't worry about this benign finding, or it could be, hey, it came back as benign, but I'm still not too sure. You might still have to go to a surgeon. So those are very, very different things for the patient. Really important part of our job, I think.
I echo your comments, and I think this is it's a part of what we do that I don't think is talked about as importantly as it is. Doing a biopsy is one thing, but the correlation is really the heart of what's important with that, not even as much as recommending the biopsy. And I think it's very unique to breast imaging historically that it's very unique to what we do. I don't know about thyroid biopsies or prostate biopsies where they do the RAD-PATH correlation like we do and make those recommendations. I mean, the procedure isn't done until the correlation is done. And very often I'm very comfortable with calling my pathologist, going over the imaging and vice versa, discussing it with our surgeons. Again, it's not who recommended the biopsy, but who performed the biopsy, because they were there, they actually put the needle into it, and they understand how difficult it was or what it would look like when the needle was there. And that correlation is extremely important. We used to answer your question, Dr. Jacoby, when I first got here, we used to all meet with the surgeons, the oncologists, and the pathologists really early, I think like 6:30 in the morning, with a multi-head in pathology department with 6 microscope heads, and we would go over the pathology together. And it's a learning as well as a concordance conference, but that's just logistically too hard to do these days. And so now, we're kind of doing it on our own, but it's still very important. We have to document, as most people do, with an addendum usually to the biopsy report, that it is concordant or not and what the recommendations are.
But to what you said, I agree that it's so important to have a good relationship with your pathologist and just not be afraid to pick up the phone.
Yeah, absolutely. We have to jump on our clinical colleagues. Sometimes they want to get the patients the results so quickly that they come out that they give them the results, everything's benign, and then we say, wait, we haven't done a RAD-PATH yet, and then there's just some discordance, and then you have to call the patient back and say, well, we may need some more sampling or whatnot. So yeah, they've been educated on it. It's very important that they don't talk to the patients until they know that the radiologist has done their correlation. So
yeah, that part is actually really important, because we've had some cases where it comes back as, ADH or something. And if we don't do the addendum fast enough, sometimes the clinicians will be like, okay, like I don't see the word cancer in here, right? Nothing's invasive. And so they end up just telling the patient like everything's fine. Whereas obviously with, our high risk lesions, it does warrant, I know it kind of varies, but at least with AJH and like, radioscopic, that sort of thing, it does warrant, a surgery appointment, which is a pretty big deal. So I totally agree, making sure that correlation is well established in the report and everything really helps our clinicians give the right information.
At everyone's institution, who's giving the results to patients?
That's a good question. So I'll go first. Historically, at our institution, we defer. I'm in a breast center, so if they're coming from the surgeons and the oncologist next door, they give them the results. But if it's coming from the community or one of our internal medicine doctors in our healthcare system or family practice, we have asked in the past to have their primary doctor give them the results. However, I think that paradigm is changing now because and the reason is we've wanted to give the results as a radiologist, many of us do, but they've already established care with their doctor, and the doctors tend to be a little bit more possessive of their patients. And since we don't have established office hours, it wasn't very feasible for we do maybe 6 biopsies a day or whatnot to have that kind of rapport. However, I think with the pandemic, we've seen that now with telemedicine being very much more easier to perform, we're looking to take that back and actually be the one to contact the patients and establish kind of like a teleconference where we give the results to the patients, explain to them what it means, go over their imaging, and give them the recommendations directly. I think they do see us as their doctor. I feel like it's if I'm their doctor once they're care on. A lot of times these lesions are found on screening. We're the first ones to find it, talk about it, discuss it, recommend the biopsy. We know more about it than the referring doctors do a lot of times, and I think it's better for patient care and continuity if we give those results to them. Mm-hmm. I don't know. I'd be curious to see what everyone else thinks, how they do it.
So at my institution for a very long time, we have always been the ones to give the results. Mm-hmm. So we do it over the phone, whether it's malignant or benign. And so what we first do is if it's benign, we just go ahead and give the results and talk to the patient and tell them the recommendations. And they also receive a letter afterwards. But and then they, receive a reminder if they're asked to come back in like 6 months after the biopsy, then they'll receive a letter. But we give them the results. We document it in our as part of the biopsy a report. At the end, it says, I discussed this with the patient, or I gave it to my nurse to tell the patient if it's something very simple. But if it's malignant, our tradition has been that we call the referring physician and talk to them and ask them, would you like to inform your patient or would you prefer us to? And as a general rule, they want us to give the results. So we do. I know that during in a prior job, a lot of people think that this is not okay, that you really have to give malignant results in person, or maybe it's better by the referring physician. But I think that as time goes by, I feel that when you have a breast biopsy, it's so emotionally difficult that you really want to know those results as soon as possible. And I know that a lot of people say, oh, well, don't tell them on Friday because they can't do anything. But they can. They can emotionally go through a lot on Saturday and Sunday so that Monday they can, kind of face everything with a little bit more of resilience, et cetera. So I really think that I think it's hard to be waiting for biopsy results. And so I do believe that it's kinder to tell people quicker. But I know that there's a lot of different thoughts on this.
I think there's been some change, and I don't know what the status is in everyone's institution, but the recent legislation to have all results be immediately released electronically and available to the patient. And so again, I've had experience at 2 different institutions. This current one is fairly new, just a few weeks. But a similar process and similar to what you were saying, where we call patients with benign results, offer and contact the ordering physician for malignant results. Often, their patients have a relationship with their primary doctor for sometimes decades, and they prefer to be in touch with the patient. They have a referral network established. They have a facile arrangement to make the referring appointments with breast surgeons. And then when working with patients who have already previously been diagnosed with breast cancer or who have additional biopsies or who have a breast surgery relationship, I've worked with a lot of breast surgeons who prefer to contact or have their team contact the patients with the results so that they can offer additional steps and information and answer questions right away that the patients may have.
I saw there was a question from a nurse navigator. I don't know if you want to look at that.
Well, first, Tiffany, what were you going to say? What do you do at your institute?
I was just going to quickly say I've kind of been on both sides of this. Trainee, when I was a resident, I remember that we would call patients if they had benign results, and then we would have patients with malignant results come in person. I believe with a nurse navigator, we would have that conversation with them where we gave them the results. At my current institution, kind of interesting. So we don't give the results ourselves. When pathology results are out, they CC both the radiologist as well as the ordering provider. Because when we put in the order for the tissue sample in the first place, we put the name of the ordering provider as well. So we basically get the information at the same time. And so far, our clinicians have been doing a great job at sharing the pathology results. Of course, they always know they can call us if they want to clarify anything. But I think there is some ownership in that sense that they've known these patients for quite a bit of time. They have some rapport with them. Now, of course, you can always make the argument, I think someone was talking about this, that some of our findings are screen detected. So it's not like we have just as much, in the pot as other doctors as well. So I do see the utility of giving patients results that we perform the biopsies of. I think a lot of the reason why institutions wouldn't do that is just logistics, just having a huge patient volume, doing so many biopsies every single day, and then also making time in your diagnostic schedule to speak with patients either in person or on the phone. I think that's the biggest obstacle. If that was not an obstacle, I think ideally we should be talking to all of our patients about our biopsies. But unfortunately, that would also mean maybe less biopsies done overall and maybe less diagnostic workup. So a fine balance, I think, has to be met somehow.
And then everybody at your institution, the question was brought up of nurse navigators and what are their roles. Do you guys have nurse navigators at your institution?
I'll start. We have a nurse navigator at our institution for several years now. She's fantastic. However, we share her with the clinic. So she's mainly with the surgeons and the oncologists, but she's really for the whole breast floor, including which is imaging. However, she doesn't get directly involved with our biopsies per se, except if after hours, after we do the biopsy, if they have a question when it's, let's say, in the evenings or on the weekends, she does allow us to provide us her email to them, her card. So if they have any questions or concerns, they can call her, and she's also a nurse. So that's really helpful, although we do call our patients the day after to make sure they're okay, but these are more for emergency situations and to help triage. But yeah, that's the capacity which we use a nurse navigator, apart from our multidisciplinary clinics and tumor boards and whatnot.
We have two amazing nurse navigators, and we love them, and they do a lot for us. So, for example, when somebody has a benign biopsy, I will call the patient to give results. But I confess that, the day's so busy, right? So I make one phone call, and if the person doesn't answer the phone, it goes to the nurse navigator, and she informs the patient. The other thing they do is if somebody has cancer, they will, after I talk to them that same day, within an hour or two, my nurse navigator will call the patient with appointment for an MRI, because we do MRI routinely for everybody who gets breast cancer. So they'll find them an appointment with an MRI. They'll get them appointments to see the surgeon and oncologist. So they really get very involved, and they're amazing at taking care of patients and to just calm people down. They're really actually great.
Does your nurse navigator deal with authorizations too?
Yeah, they do.
Does anyone else have a nurse navigator at their institution? Okay.
Not me.
Well, we've had somebody that sort of functions as a nurse navigator. Her biggest role that was really, really useful was helping us do our rad path addendums, actually. And so she was very, very good at keeping us on track and actually putting in the addendums. Of course, like checking them with us as well too. She had many other roles as well, but she's been on leave. So unfortunately, we've had to do a lot of it on our own. But it's not too bad to kind of remember all the important things that we need to do as part of the process. So.
Okay. Does anybody else, or do you guys have anything to add on that, or we can move on to seemed like a topic that is kind of difficult to get a consensus on. So we'll go ahead and talk about so I wanted to go from biopsies to needle localization. So people can do these differently, different techniques, different technology. So I was wondering first if someone can we already talked a bit about how the procedures are done. So what kind of technology do you guys use at your institutions to do these procedures?
Localization specifically?
Needle localizations. Do you use a wire? Do you use Savvy's seeds?
We use Savvy's. We've transitioned to wireless, but we still have wires for the surgeons who feel more comfortable with the wires. Some of our surgeons have a lot more experience with the Savvy, and others are getting up to speed. So we have both. Personally, I love the Savvy. Once I started using it, I would like to use it on everybody, but there's some cost concerns with that. But it's very easy, quick, and patients love not having to have wires out. It really frees us up as far as scheduling and timing of that. It's really made our schedule a lot easier, and uncoupling the procedure and the surgery, and then also for the neoadjuvant patients and whatnot, it's been a boon. So it's great. Anybody else use wireless?
Yeah, we use the Savvy and wires, but in our case, we use wires preferentially because my understanding is that wires are extremely inexpensive. And then that the Savvy is, I think it's over $500. So what they say is that the institution almost, I don't know, they feel like it's a big loss of whatever profit there is, I guess they wouldn't word it that way. Let me be politically correct here. It's just, it's very costly. Let's just say.
Just from my understanding is, you're absolutely right. It is like much more expensive because it's a different technology than a wire. Wire is very inexpensive and it's time tested to work. But if you don't put Savvy's the same day of the surgery, then you get reimbursed not more than the full amount of what it costs. That's Savvy cost. So, but if you do it the same day, you're going to take a big loss. See, we never put Savvy's on same day surgeries. We only do it if you're going to be earlier.
I guess I don't know enough about it, but my understanding was that there was a big cost difference, and that's why they only reserved it for the that person that the surgeon wants to get in at 7 a.m. So that's what's happening at our institution. In general, we don't use them, but maybe we're just not doing the right thing for reimbursement. Maybe you can educate me afterwards and let me know.
I can send you that, because we did look into it, and that was our understanding, because we're definitely being cost conscious here. And that's the only reason we would use it. We wouldn't use it otherwise. In fact, if you know something's a BI-RADS 5 lesion, and we could talk about BI-RADS later for the public who doesn't understand, but for very high suspicion lesions that we know is going to come out, or the surgeon knows that they're going to maybe want to do neoadjuvant, we may just bypass the clip altogether and save a step and just put the SAVI in those situations. Obviously not things that fibroadenomas and stuff like that. And that would even be more cost savings overall because you can eliminate one procedure.
Do you use that for stereo? Like, and does it migrate and things like that?
Use it for stereo. You can use it for ultrasound. You can't use it for MRI yet. I know it sounds like I'm teaching savvy, but I'm not. I was a critic because I always challenge them, but it has worked, and they are coming out with different sizes also. So if you need to bracket, but right now we don't bracket with it.
Yeah.
Again, you got to have to buy it from the surgeons because if they don't feel comfortable using the probe and if they're trained with the wires, it's hard to switch. Yeah. But it does make things a lot easier if it's very quick and easy for us. Yeah.
Do you use the SAVI in axillary lymph nodes at the time of biopsy?
Yes. And
prior to neoadjuvant?
Yes, and that's really good because axillary lymph nodes shrink very quick. We do a lot of neoadjuvants nowadays, right? So they shrink right away. And if you're part of I-SPY, they're going to be getting chemotherapies and whatnot, different trial agents. And so the SAVIs really, really do help with that. So we put it in before we start the neoadjuvant.
That's a really good point because sometimes when we go back to localize those clips in the axilla, they're very hard to see.
Absolutely.
And you can't many times get them, get the post, right?
Right.
They don't migrate too because of the size, and with the two prongs, they tend not to migrate. And you're not dealing with the radioactive seed and whatnot,
right.
So it tends to work.
So when the pathology comes back that the lymph node is positive for cancer, you bring the patient back and do a SAVI then?
Depending on the surgeon and after they talk to the patient, if the plan is to do neoadjuvant, we wouldn't preemptively do it, but if the plan is to do neoadjuvant,
right.
Oftentimes the surgeon would ask us to put the SAVI in, once we've confirmed it's cancer, into the clipped node, so that when the thing does shrink, assuming it will, it's easier for them to make sure they capture that at the time of, if they're going to do breast conservation or if they're even going to do mastectomy with axillary surgery. Now, if they're going to do a full axillary dissection, it may not be cost necessary to do that, but if they're targeting those lymph nodes, then yes, we would.
Yeah. And you have no problems with reimbursement with that?
I haven't seen any problem with reimbursement. I haven't checked the numbers. This is what I'm told. The numbers are it's like 10 times more. I mean, a wire cost maybe, I don't know, I'm just saying $50, maybe $45. A SAVI could be upwards of $500, $550 per SAVI, but I think the reimbursement is like, instead of $100 for the wire, it's like $700 for the SAVI, as long as it's not on the same day. It could be any 24 hours later. It just cannot be the same day. They will not. They'll reverse you the $100 as a load, and you're going to eat a lot of money. The hospital will. So, but these SAVIs can be in there for up to a year. So, I mean, the only problem is if you do it, if you put it in instead of the clip, let's say, and then they end up deciding to go somewhere else that doesn't do SAVIs or have the probe, then they have to figure out you're out of the money. So they have to put a wire in anyways. But apart from that, we use it pretty carefully.
Have they been approved to be in situ for longer than a year?
I think they've been approved for up to a year now. Things keep getting updated. So I don't know in the last so many months.
Yeah, I think they can be in just like a clip now.
I think so now.
Definitely is what I was told. Yeah.
I've used a few different localization devices. I've trained at a number of institutions, from fellowship to my previous job. My prior job, I was using primarily pretty much 99 to 100% of the time radio seeds. And so that program can be a little, I think, onerous to start in terms of regulatory standards and, production and a source of radioactivity. But I think once it's up and running, it was a very easy, smooth process. Prior to that, I had used SAVI Scouts in fellowship, and just the technique was a little better than SAVI Scout. It was a little less cumbersome of a device. And I think in terms of cost effectiveness, for production, they're fairly inexpensive. Mm-hmm. And that was a nice process. Those had to be removed, based on our nuclear medicine regulations within 5 days. But as you mentioned, it's nice to uncouple the procedure from the surgery. I think primarily for the patient, because on the morning of the surgery, they're often, NPO for quite some time. They have to sit upright. The breast is in compression often for mammographic localization. And so there's a lot of vasovagal reactions that may happen for the patient. But again, there's sort of a few interests in terms of the localization devices that are chosen for an institution, and that's also surgeon preference. So at my new institution, I'm doing primarily wires, again, based on familiarity, I think, of the surgeons. There was a trial of a different, I think the Hologic tag, which left a large tract. And so I think the surgeons were having some trouble in the operating room with dislodgement, although, that's just what I've heard because I haven't really actually placed many of those.
There's a question about the SAVI not being detected after a deployment. So part of the protocol that's recommended is we have a mini probe in our radiology suite, just like the surgeons would have it. So after we deploy it, we do confirm that there is signal through the skin before the patient leaves. If not, then we would place a second one, I would suppose, and just get reimbursed for that one. But in the case that I've done, I've not had one that it hasn't given the signal. When we first started this, one thing to keep in mind is I found it very difficult with your thumb and finger to actually sometimes get it deployed. It seems to be stuck sometimes. I don't know if you guys have that problem, and it was very annoying. But I think I've got it to the point where most of the time I can deploy it pretty smoothly. But that was a big challenge initially.
Yeah, there's definitely a learning curve, I think, with the SAVI. I mean, at my institution, we do a mix of both. I would say that majority is going to be wire based, and it just has to do with surgeon preference. But we are starting to do more and more SAVI scouts. I think that if you haven't done a SAVI in a while, let's say, you kind of have to remind yourself on how to deploy it, because from what I remember, you kind of have to unsheath it, but you also have to make sure that you're not moving the actual device itself.
Right.
And otherwise your reflector, right, is going to be not accurate. It's going to be too far away from your target. I do see a lot of utility in SAVI Scout. Certainly, if I was a patient, I wouldn't want to have wires sticking out of my breast, even though, we obviously tell people about that beforehand. And of course, uncoupling the schedule is a really big deal. Now, with regards to placing SAVI Scouts in, let's say, BI-RADS 5, like lymph nodes, we're starting to do, we have been doing kind of a trial of that. The worst cases that I've ever had, the most stressful cases, are ones where, you biopsy a lymph node, you place a clip, it comes back as malignant, they undergo treatment, and then they come back and the surgeon wants you to load that lymph node and it's not there anymore, right? And all you have is that clip, and you pray, you go to ultrasound, and of course you don't see the clip. There's a bunch of, vague sort of things, and you don't know if it's there. It's not the best place to do a mammoloc or, for that either. So it's really, really stressful, to be honest. And putting a SAVI Scout kind of earlier on, if you're convinced that it's going to be a malignancy, I think really kind of solves that sort of anxiety. So that's a really big part that I would like to see a little bit more and more as we continue using it.
One recommendation I may give also, if you haven't tried this, I don't know what clips you use, but clips come in various sizes and shapes, and a lot of them are really small and it's hard to find. And you may be familiar with the 2-mark clips from Hologic. They are bigger. They're made out of nitinol. They have bigger shapes, and they're just much more, for me, visible under ultrasound. And I prefer to put that, even if there's already a clip there, if I know that I'm not leaving the SAVI and it may go away. So you may want to look into that. They come in different shapes. It's a direct puncture. It's an 18 gauge. So it's like a IVC filter. It has nitinol, so it can preform once it comes out at body temperature. So it comes out small through an 18 gauge direct puncture needle, but then it opens up a little bigger.
Right? I think I've heard about this. Yeah.
Yeah, try it. It's really slick.
Yeah, that's what we do in the axilla as well. The 2-mark Vision, I think it's called, is the one that really shows up the best.
Yes, that's a nice one.
There's also a Q, but the Vision.
Yeah, we use the Q or the Vision.
Yeah. Wonderful.
What clip do you guys use otherwise?
I actually use it on everybody.
Oh, you do it on everything?
It's the same
We
process.
use a Hydromark, and it seems like we normally see it, but sometimes, I guess sometimes not, but as a general role, we do see it pretty. Does anybody else use Hydromark or no? What do you like?
No.
Used to, but surgeons don't like it. Sometimes it slips out of the OR, and we've had migration issues when we placed it. So yeah, that's the only reason we didn't use that.
So there was a question about the Savvy Scouts and when you might not be able to hear it with the handpiece, even the one in the procedure room.
It's not really recommended, by the way, for if it's really deep in the breast, especially if they're, really large breasted and you're way down by the chest wall, they may have a hard time to probe catching the signal. And surgeons who are not experienced should probably not be using it at that point. But that would be one reason I would caution.
I've definitely run into that case before with somebody that just has a lot more tissue,
Mhm.
like by volume size, and we're placing the Savvy Scout like really, really far back. But of course, you really have to make sure that you do get some signal. Otherwise, if you can't get it, then there's no way you can guarantee that the surgeon can get it. So I think in that case, we did a lot of repositioning. It just kind of scanned all different ways to finally get it. It did take like a few minutes to get it done, but I certainly have had that experience, and I think it does have to do with just traversing, like the everything just traversing so much tissue.
Keep in mind also, sorry, I didn't mean to, go ahead. The axilla can be very big too, and sometimes there can be deep lymph nodes and someone has a lot of axillary tissue. You may not get a signal with the Savvy if it's really deep.
And also what we do when we get the signal is we'll give the o'clock position and the distance from the nipple to the surgeons. We'll put that in our report so that they have it. So hopefully that will help them when they're trying to hear the signal in the OR. And then a hematoma is the other thing that we've run into. When there's a very large hematoma, the signal may not be heard if the Savvy Scout reflectors within the hematoma. So, but you can always put it on the edge of the hematoma for the surgeon to hear it that way. So we use Savvies a lot at our institution, and we use wires when needed. And surgeon preference. How was it when you switched over from wires to Savvies?
There was a little bit of pushback from some of the surgeons because they weren't comfortable not having the wires. They've always used wires. We had one of our surgeons come over from back east Midwest, and she's been using Savvies for 2 years, and so she was uncomfortable with wires, and so she got the other ones up to speed pretty quickly. Some of them had to go cold turkey, but they picked up pretty quickly, and we loved it. So we're like, yeah, we're pushing it. But yeah, at the end of the day, it's a surgeon preference because we can do what we want, but they're the ones that have to take it out.
Right.
So.
Yeah. Our surgeons love it.
Good.
Does anybody use Hologic, and why not? For us, we just started with Savvy, so we just stayed with it. But
what do you mean Hologic?
The tag.
Hologic has a different version of the Savvy.
I only seen it, so like I mentioned, only been here at Cooper for a few weeks, and they have been using it, but from discussion with the breast surgeon, it sounds like the group is going to try to transition to Savvy Scouts because they've been unhappy with it in the operating room. I've seen the device. It's pretty large. It's pretty sizable of a localization device. And I don't know what gauge it is, but it's very, very sizable. And so I think that's been some of the issue. So there's a huge shadow when you do your initial localization images. And then I think the surgeons have been having trouble with dislodge or displacement of the device. I don't know if that has to do with the size of the device. And then also I think a little bit of a difficulty with localizing the signal in the operating room. But that's, my very limited experience with it.
Thank you.
All right. So we talked about some of the technological advances with going from wires to Savvies and seeds, and now the Hologic tag as well. What has everyone found to be kind of their favorite advance in technology for procedures that's made the patients' lives easier, our lives easier?
I have two. One is the Savvy, obviously, because I think it's the one thing that we've been using wires for 40, 50 years, and finally we've advanced past that. And number two for me would be doing stereotactic biopsy with tomosynthesis. I think, not having to do the plus and minus 15 degrees and marking and all that stuff, it's just made the procedures go by so quick, so easy. I think that's to me that cut the time in half, and just the accuracy, it's so clear. I think those two, from a procedure standpoint, I think those are the two big ones for me.
I'm going to go with Stereotomo as well.
Yeah.
I would agree with that. I think, it seems pretty straightforward for us, local anesthesia, breast biopsy, outpatient procedure, but particularly for the mammographic guided biopsies, and MRI. But the patient has their breast in compression, it can be very uncomfortable. And so any shortening of the procedure that you can do, I think really helps the patient. And I find tomosynthesis biopsies are just so much faster. Patients are in compression for less time, samples are great. So I've been, very, very appreciative of that.
Yeah, I pretty much agree with what everyone has said. I've been lucky that, during my training, we kind of like always have had stereotomo. So I think I'm perhaps spoiled by it. But yeah, now if I really think about it, I would certainly miss it if we didn't have it. So let's put it that way.
My first stereo biopsies were with core needles because they didn't invent the vacuum yet. So
I know. Remember how much time that used to take? You had to get the needle.
Each one you had to take out individually.
Yes. Yes.
We're spoiled.
Yeah, the 3D biopsy, the tomo biopsy is great too, because now we're finding all these subtle distortions on as more people get 3D tomosynthesis screening mammograms, and to be able to target those would be actually impossible without the 3D technology. So I would agree. And has anyone used the lateral arm? You guys have that at the prone stereo table?
We have a prone stereo table.
Yes.
Does it have the lateral arm on it? It's one of the newer features of it. So you can approach the breast from a different angle, and you can biopsy thinner breasts.
Yes, I actually love that, because sometimes when you have things that are subtle, let's say you put it in the CC and interlaterally. So when you put your anesthesia, it's closer to the skin, and it's not kind of distorting your view of the deeper things. So yes, I love that. That's actually, I guess, part of this whole new, once they started the Tomo. Yeah. I agree with that.
Yeah.
I don't. I just, maybe it's a little bit of a conceptual thing, but I like to have the compression right at the target. I feel a little worried when I'm coming in, at the angle of or I guess parallel to the compression angle. So I get a little worried there. So I haven't been using it as much, but I know some people and some radiologists who really love it.
Just to circle back to the other one, why the Tomo also is helpful is sometimes you could much more easily see if there's a vessel kind of crossing right along the path that you might have missed, and that save you maybe some headache with bleeding later on. Yeah.
Absolutely.
Yeah. And circling, is anybody else? I think we finished that. Circling back, there was a question about, and Stephanie, I think you said that you used a seed and the Savvy at some point.
Yes, I have.
What would be your preference, or what are the pluses and minuses of each?
I think for placing, I prefer the RadioSeed. I think that because it's just a slimmer device, you have a little more manual control over the apparatus as you place it, and so it's very similar to a wire, with a thin caliber device. The needle is very thin. The Savvy, I think, as Dr. Chen mentioned, can be cumbersome, and so you really have to be careful that you're not jostling or moving the device in or out of the breast as you're moving the tab over to engage it and then pulling back. It's sort of a different type of deployment, I think, than most other devices where you push forward. And then I just got very accustomed to doing the seed. And so I really, found that it was very accurate when you deployed it right where you would expect it to be. With the Savvy Scout, you have to be a little anterior to the lesion as you uncover it, I think 6 millimeters from what I remember. So I think I just felt a little more facile and a little quicker with the RadioSeed, which, I'm always trying to do the procedures as quickly and accurately as possible for the patient comfort.
Okay. Does anyone have any final thoughts, what they want patients to kind of take away from this talk about breast procedures?
I just want to say that, breast biopsies is something that we have championed, and it's something that we have a lot of experience with. And it's really one of the boons to what we do as breast imagers, because we find things, but we need to know what it is. We can't just find things. And having a minimally invasive way of quickly, accurately, and really almost harmlessly, painfully getting a diagnosis is, I think it's really one of the best things we do in breast imaging. And I really want to thank all the breast imagers out there who do it and perfect their craft, because it's something that is of so much value to the patient.
Yeah.
So, yeah.
One thing I wanted to mention, we had talked about the microclip and how it sometimes can cause a little bit of confusion, anxiety, that sort of thing, about having, a foreign body kind of left in your breast. If, let's say that, you didn't have to go to surgery. So actually, about a year or two ago, I developed like a patient educational handout that kind of discussed, some common questions. Things like it's not a tracking device, and like, yes, you can go through airport security, not set up alarms, that sort of thing. But some things that I thought were also very useful to include on this handout were, I actually included little diagrams of the microclip, like drawn to size, so people knew exactly how small it was. I also include a little picture of a mammogram, and it's not like you need to know how a mammogram looks, but there's a clip on the mammogram so you can see how bright it is. So it kind of shows patients too, how it's useful for us doctors. And if they were to, let's say, get their care somewhere else, we all speak the same language. We all know that a clip can only get there by a biopsy, So this handout actually has really helped, I think, patients. And they're obviously always welcome to ask us questions. I only created really because I felt like so many people were asking very similar questions. And I just wanted to give like a good summary for people. So that's always an option as well too. I don't think it's caused extra anxiety, which is, a thought I had as well. But I think, it really empowers patients into understanding the importance of the clip, because it can actually be a source of a lot of confusion for many patients. Just want to share that.
Patients have a lot of, and I'm glad you brought all that up, Dr. Chan. Patients have a lot of anxiety about clips, and understand, because they don't know, and they prefer not. They're more concerned sometimes on some patients about the foreign body in the breast than they are even about the biopsy itself. And to try to reassure them, like, well, do I really have to have it? Can you do without it? What if I decline? And they're adults, and we need their consent, obviously. But one of the worst things I try to explain to them that can happen, and we get patients from outside, it happens, is where someone does a biopsy, causes very little distortion to the breast or whatnot. You get cancer cells or something atypical or something, and we don't exactly know where it is, and now you're stuck. Now you have a cancer cell in there. You don't know exactly where it came from, and yet, what are we left with? Either doing some imaging to hope to find it, or mastectomy, I guess, if you don't know where it is and you got cancer cells. So it is really important. You don't know what the results are until the pathology comes back. You put a needle in the breast, you take tissue, you put a clip. That should just be the rule, and explain why it's so important.
Yeah. Well, I just wanted to, we're about out of time here. And I just wanted to thank everybody, our panelists, and also everybody out there listening. Hopefully this kind of gave you some new information about breast procedures, or refresh some information you had. And I wanted to remind everybody that the summer series isn't over yet. We're going to have next week, Wednesday at 7 p.m. Eastern Standard Time, we're going to have breast imaging toolbox discussion, basically a discussion of newer modalities. So we gave you a sneak peek, I guess, today with some of the modalities that we're enjoying as breast imagers, and you'll get some more information next week. So thank you all.
Thank you.
Thank you. Thanks, everyone.